Good evening, councillors and members of the public. My name is Councillor Ruth McEwen and I am the Chair of the Adult Social Care, Children's Services and Education Committee. I would like to welcome you to the committee, which is being held as an online meeting. With social distancing rules still in place, councillors are meeting tonight on this video conferencing platform instead of meeting in person at the civic offices. This is now the second online meeting of the ACE committee since the Coronavirus Act of 2020, which has allowed local authorities to be conducted online, attended remotely by members and also officers. The public and press can still see and hear the meeting. The agenda papers have been published on the council's website and the Modern Gov app. These papers have been considered by members. I will ask members individually to debate on the reports and to state if they are for or against or to abstain from the recommendation. Can I also please remind any councillors, if they wish to speak, to notify me in the chat box. Okay, I will shortly ask members to introduce themselves for the benefit of the public and also to ensure that they're all in attendance as expected and that they can hear and speak to the meeting. But I just remind members and officers to put their microphones on mute when you're not speaking. And when called to speak, you should unmute your microphone and pause for about 3 seconds to allow for the slight time delay in connection. You must also remember to put your camera on before being called to speak, otherwise you won't be visible to the screen during your contribution. And as ever, we are at the mercy of individuals' broadband services, and it is possible that loss of connection may happen. However, as long as we have 3 members still in the meeting, we will be quorum. Okay, thank you very much. I will now call on I will call on the other members of the committee alphabetically. Please speak slowly and clearly, and remember to put your camera on when you're about to speak. So, Councillor Balston.
Good evening. I'm here to observe because unfortunately I can't be in the meeting for the whole meeting. Thank you.
Thank you. Councillor Grasshoff. Do we have Councillor Grasshoff there?
I think she might be having difficulties logging in. I know that she's due to attend.
Yeah, okay. Councillor Hoskin.
Hi, I'm Councillor Graham Hoskin and I'm the Lead Councillor for Health, Wellbeing and Sport.
Thank you. Councillor Jones.
Good evening, Chair. My name is Councillor Tony Jones and I'm the lead member for Adult Social Care.
Councillor O'Connell. I think actually Councillor O'Connell may be having problems connecting, so we'll take that she's here. Councillor Pearce.
Good evening, Councillor Ashley Pearce, and I'm the lead member for Education.
Councillor Robinson.
Good evening, Chair. Councillor Simon Robinson, Peppard Ward Councillor and representing the Conservative Group on Children's Services and Health.
Thank you. Councillor Terry.
Good evening, Chair. Councillor Liz Terry, a lead member for Children's Services.
Thank you. And I do apologise, Councillor Absalom.
Good evening, Chair. Councillor David Absalom, Redlands Ward.
Sorry, not very good with the alphabetical order, I'm sorry. And Councillor McKenna.
Present.
Thank
Although
you.
I need to clarify, am I on committee tonight?
You certainly can be. You're very
Happy
welcome. Right, thank you, councillors. I would also like to introduce you to the officers who are in
Hello,
attendance.
Chair.
Sorry, I've missed somebody out. I am sorry.
Councillor White here.
Councillor White, I apologise. Councillor White, would you like to introduce yourself?
Yes, please. Thank you very much, Chair. It's Councillor Rob White. I am a Park Ward councillor and the leader of the Green Group of Councillors. Thank you and evening all.
Thank you, Councillor White. Apologies for that. Right, okay, thank you, councillors. I would also like to introduce you to the officers who are in attendance tonight. They will not be on the screen as much as councillors, but it is right that I introduce them so that you know who they are and what their role is. And we have Melissa Wise, who's the Assistant Director of Commissioning, Transforming and Performance. Would you like to introduce yourself?
Sorry, Chair, I was struggling to get off mute. Yes, good evening. My name is Melissa Wise. I'm Assistant Director for Commissioning in Adult Social Care. I'll be presenting an update this evening on our response to the COVID pandemic. Thank you.
Okay. And we have Jo Taylor-Palmer, who's Locality Manager, Safeguarding and Adult Social Care.
Good evening, Chair. Yes, Jo Taylor-Palmer, working alongside Shona this evening to present the Safeguarding Board annual report.
Thank you. And also we have Shona Douglas here.
Good evening, Chair. I'm Shona Douglas. I'm the Executive Director for Social Care and Health here at Reading Borough Council. And as you heard, I'm presenting the Safeguarding report and here in my Executive Directorial capacity.
Okay. And we also have Kate Reynolds, Director of Education for Brighter Futures for Children.
Thank you, Chair. I'm Kate Reynolds, Director of Education, Brighter Futures for Children, and I'm here tonight to present the report around admissions to schools. Thank you.
Okay. And also Deborah Glassbrook from Brighter Futures for Children.
Yes, good evening, everyone. I'm Deborah Glassbrook. I'm the Executive Director for Children's Services here in Brighter Futures for Children and Reading Borough Council.
Thank you. And we also have Richard here, who's from Committee Services. Okay, thanks everybody. And moving on, if we move to agenda item number 1, declarations of interest. I just want to see if anybody, I have been advised of one councillor. Has anybody else got any declarations of interest? Just okay, thank you. That's Councillor White has declared an interest in agenda item 11. Okay. So agenda item 2, we're moving to minutes of the previous meeting. Are there any matters arising from the minutes? No, I take that. Fine. Okay, thank you. The minutes of the meeting of the Health and Wellbeing Board from October 2020 have been included in the papers for information. Okay. Agenda item 4, petitions. We haven't received any petitions for this meeting. Okay, thank you. And then agenda item 5, questions. I have received one question from Councillor White. Councillor White, please can you ask your question? Okay.
Thank you, Chair. This question is on the weekly food hamper for some school children. Chartwells is one of the providers supplying weekly food hampers to parents and guardians during lockdown if their children qualify. Some hampers being distributed around the country are woefully inadequate. Can the lead councillor confirm what work has been undertaken by the council and Brighter Futures for Children to ensure that the food hampers being distributed in Reading are adequate?
Thank you, Councillor White. Councillor Pearce, would you like to reply on my behalf? Thank you.
Thank you, Chair. Thank you for this question. The Council and Brighter Futures for Children remain committed to providing high quality meals to our most vulnerable children. All hampers supplies should meet the Local Authorities Caterers Association requirements for nutritional value. Chartwells has advised Brighter Futures for Children that every unit manager will need to take photos of the produce going into a hamper and a photo of a completed hamper box for the area management to approve as ready for pickup. In the event that schools and families feel the hampers did not meet the requirement, we will be seeking a refund of the costs. With our commitment to tackling food poverty, we have worked to secure that the National School Voucher Scheme will be rolled out from 18th of January 2021, so it's now a couple of days old. This will enable families to provide for their children in a way which meets their needs rather than rely on food hampers. We will, of course, contribute to any national inquiry into the quality of school meals if asked to do so.
Thank you, Councillor Pearce. Councillor White, do you have a supplementary question?
Yes, please, Chair. And thank you, Councillor Pearce, for the answer. I think it's fair to say that Chartwells haven't covered themselves in glory on this. Can you clarify if we are seeking a refund for any vouchers at the moment? Well, not vouchers, hampers, sorry.
Thank you. We had over 1,000 hampers delivered last week. We had 225 in schools. We had 12 people contact us, either the schools or parents, and we'll be chasing those up.
Thank you.
Thank you. That concludes questions from councillors. We'll now move on to agenda item 9, which is decision book references. And we do not have any decision book references, so we'll move on to the next agenda item, which is it's an update from the redevelopment of the Royal Berkshire Hospital. And so we're going to be joined by Nikki Lloyd, John Underwood, Andrew Stratham. We're going to give a presentation on the redevelopment of the Royal Berkshire Hospital.
Thank you very much, Chair. My name's Nikki Lloyd. I'm the Acting Chief Executive at the Royal Berkshire Hospital, and as you said, I'm joined by my colleague John Underwood from Freshwater Communications and Andy Statham, who's the Director of Strategy, Transformation and Partnerships at the Trust. First of all, thank you so much for inviting us to join you this evening. I really appreciate the opportunity to come and tell you a little bit more about what we're doing on the hospital redevelopment. If I may, Chair, first, I'd just like to start by thanking everyone at the Council for their huge support in helping us to set up the adult social care hospital discharge beds at the Holiday Inn South in Reading. These 20 beds have been an absolute lifeline, not just to patients, but to us. As you know, in the last couple of weeks since they went live, they've accommodated 19 patients, which have saved us 92 bed days in the hospital, and it's made a hugely positive flow on patients and on our staff. So we can free up beds there for really sick people, knowing that the other patients are being safely discharged back to the Holiday Inn for convalescence and re-enablement, ready for their return home. So thank you very much to the Holiday Inn and the Council and Care First Home Care. It's a really fantastic example of how, as anchor institutions in our local health and social care partners, working well together for the benefits of the community, and one of the very many fruitful partnerships that we've established together within Berkshire West. And as always, the huge support and goodwill, including inviting us here this evening, to the hospital and our staff is really appreciated, and a real boost to us all as we go through these difficult times. We are under quite a lot of pressure at the moment, and one of the things we're obviously keen to talk to you about is how we can redesign the built environment to make a space that's better suited to patient care. If I may, I just wanted to please ask for your help before I start the presentation as well. If everyone on this call can please use their influence and make sure that everyone who's scheduled to come in for care attends their appointments as planned. We're still trying to make sure we can diagnose and get people started on treatments as soon as possible. And also, I know the council's doing a lot to promote the hands, face, space guidance. Really, really important to keep the disease spread controlled as far as possible. So we are open for many services, and I'm going to bring my colleague John Underwood in, who's just going to take us through a short presentation which summarises where we're at with our strategic outline case. We submitted it just before Christmas, and then Andy and I are open for questions if you'd like to ask us anything about what you've heard on the Building Berkshire Together presentation. So John, if I can hand over to you, please.
Thank you very much indeed, Nikki, and thank you, Chairman, for this invitation and so on. And I think Richard is going to share a very brief slide presentation, which sort of is intended to update everybody. I should explain I'm the Communications and Engagement Advisor on this exciting project, and I must say it really is a very exciting project to be working on. Richard, if we could go to the next slide, please. Thank you. So a quick word of background, as it were. The Royal Berkshire Trust is able to proceed with this project to redevelop its buildings and facilities, and indeed its services too, because the Government Health Infrastructure Programme, the so-called HIP programme, is providing funding for new hospital projects over the next 10 years. The HIP programme was launched just over a year ago, and I'm very pleased to say that the Royal Berkshire Foundation Trust is one of 21 NHS trusts to have been given seed funding to develop ideas for new and refurbished hospital facilities. And over the course of really pretty much the past year, we've been developing a strategic outline case for the Treasury, which identifies a number of options or scenarios for future development. And I think it's important to say at this stage that while we've got a number of options, and it's my great pleasure to run you through some of those over the next 3 or 4 minutes, I should stress that all development possibilities, all the options are very much remaining on the table, as it were. No decisions have been made at this stage. Everything is up for being considered and discussed. I think the crucial thing is that this is a major opportunity for the NHS and for our local communities as well, when it comes to sort of the concept of improving services, improving patient experience, improving the environment, and of course supporting the local economy as well. Richard, could you spin us to the next slide? Thank you very much indeed. So the case for change is really very, very strong in this part of the world, and it's based on these what we've called here the 5 C's. So the first one is condition. The existing hospital buildings are in poor condition. Not all of them and not exclusively, but they all can do with some form of refurbishment or rebuilding. And the fact that the condition is suboptimal means that that can lead to, it could lead to poor patient experience, poor working conditions for NHS staff, and it can lead to high maintenance costs and possibly even safety risks too. So the first of the 5 C's is condition. The second one is capacity. The hospital is currently operating beyond its current capacity, and expected local population growth will only mean greater health needs in the years to come and rising demand for services too. And then there's the question of capability. The existing buildings were designed to support 19th and 20th century models of clinical care. And these buildings, in some respects, actually limit the capability of our staff to provide high quality modern healthcare for our local communities. And then penultimately, there's the question of climate, the climate change, the climate emergency. The existing buildings are really not just a poor environment for patients and staff, but they actually contribute to the climate emergency. What we need is green, low carbon, modern facilities which enable us to really address the local environmental issues in a more meaningful way. And then the final point is this sense of catalyst. Developing a healthcare campus for Berkshire would really generate jobs, it would encourage economic growth, it would provide lots of work for local businesses, and it would act as this kind of catalyst for the local economy for many years to come. Again, Richard, if you could take me to the next slide. Thank you very much indeed. So let me, if I may, run you through the scenarios. The first two scenarios, and I should explain, these are scenarios or options for future development. You can think of them in either way, as it were. The first two are benchmark options, which we are required to put into any strategic outline case. And these are the benchmark options against which we measure the other options. The first one is do nothing, which is an option which involves us only addressing the most high risk backlog maintenance issues, or option two is do minimum, which is addressing somewhat more than the backlog maintenance, but it still doesn't take us very far forward, as it were. I must stress there is absolutely no proposal that we should be going for either of these options. These are, in a sense, what we need to avoid. And again, Richard, if you can take me on to the next slide. The way we aim to avoid them is with scenarios 3, 4, 5 and 6. And the top one here is scenario 3. And you'll be able to see on this slide, I think, that even though the diagram is a little detailed, this involves on the current site, of course, the building of a new emergency block, an expanded A&E, a new ICU, intensive care unit, new operating theatres, and this scenario 3, and you can see in red where the new red and orange where the new buildings are kind of being built, and there's some refurbishment in other areas as well. What option 3 does, it helps us to separate emergency and planned care. And that's a big holy grail. It's a big important step in the right direction for modern healthcare. But this scenario goes some way towards meeting the requirements of the future, but it doesn't really fully meet future demand. The option 4, which is the diagram on the bottom of this slide, this involves rather more. It builds on option 3. It involves a new emergency care block, a new elective or planned care block. It involves new women's and children's facilities. And in addition to all of that, it involves the potential, at least, for a medical school. And it gives us the opportunity to grow services and to do much more than option 3 entails on its own. And Richard, if you can take me to the next slide. Thank you very much indeed. These next two options, options 5 at the top and option 6 at the bottom, these represent the stretch, the really the big steps forward, as it were. Option 5 is effectively the building of what is largely a new hospital on the present site. All the new buildings, as we were discussing in option 4, but this will be largely new buildings, and this really supports the growing demand and the greater integration of healthcare between health and care services as well. This would definitely involve a medical school, and it would involve research facilities as well, and that's an increasingly important part of modern healthcare as well, I think. And then the final option, option 6, is the building of a completely new hospital on a Greenfield site, which I must stress has not yet been selected. There's no question of us knowing that there is a site out there that we have in any way pre-selected. That simply is not the case. This is a completely new hospital on a theoretical Greenfield site that would, if it were completely new, address all of the increasing and growing local needs, and it would, in a sense, provide us with the kind of the blank canvas on which we could completely start afresh and build a zero carbon health facility. once again, Richard, if you can take me to the next slide, please. We're almost there now. All of these options that I've just outlined there, they all have different pros and cons. And here are some of the pros and cons that we're currently considering. We're considering things like adjacencies, ensuring that services that need to be very close to each other on the site actually are properly co-located. And we're considering things like the environment, developing the environment which is green and low carbon. And clearly, the more new buildings there are, the more we can build very clean, very low carbon facilities, as it were. And then, of course, there's the question of the economy. Developing a hospital which supports the local economy and creates jobs is an important consideration that we're grappling with at the moment. And this issue of compliance, now what we mean by compliance is which scenario or scenarios offer the greatest compliance with modern safety and high quality healthcare guidelines. And clearly, the more modern the buildings are, the more likely we are to be able to make sure that they do completely apply or do completely comply with modern healthcare guidance. But of course, completely new buildings also come at a cost. And that's one of the other factors that we're bearing in mind. We clearly are spending public money, or we will be spending public money, and we have to make sure that we go with the most cost-effective scenario. And then the final consideration is convenience. Considering which scenario can be most easily and most conveniently delivered. Well, in one sense, building a new hospital on a new Greenfield site would be the most convenient thing to do, but it would also be the most costly. So all of these factors are pros and cons that we are kind of seeking to judge and balance against one against the other as we look at all of these scenarios. And of course, you know, one of the things I'm coming on to in a moment is to talk about engagement, and we're absolutely intending that all of our local stakeholders should be part of that process with us and part of that big conversation. Again, Richard, if you can take me to the next slide, please. It's worth saying that there are a couple of critical issues about our case for change and about our strategic outline case. One of them is that we are very importantly and strategically located in the Thames Valley, home to one of the world's largest life sciences clusters. All of those companies that are working in all of those sectors of life sciences, which we can now see with the global pandemic, are very important and are only going to become more important. And our strategic location close to all of those companies is an important part of our strategic outline case. And of course, this phrase which is being used increasingly, the idea of organisations like local authorities and like NHS organisations being anchor institutions in their local community, is something which is very, very important to us. We are not going to be going anywhere. And while we want to deliver really great health services, I think it's important that we also play our part by doing something more and over and above and beyond that in terms of supporting the economy and improving the environment. The penultimate slide is the one that's coming up next. If you could take me on to that one, Richard, thank you. Next steps, where do we go from here? Well, this is in a sense a courtesy presentation to bring Chairman, your committee up to speed with where we've got to so far. Just before Christmas, we delivered the strategic outline case, which I've just in a few minutes summarised, as it were. We will be continuing with engagement with our stakeholders, local authorities, patients, obviously staff, all of our other stakeholders as well. And our next step is to move on from the strategic outline case to discuss that with our regulators and to get some feedback from them, but then hopefully to move on to develop an outline business case, which is really to develop the options further and to see if we can move towards a preferred option. And then finally, a full business case, which is the point at which we seek to persuade the government to give us the money to do it. And Richard, if you can take me on to the final slide, I'll then cease and hand back to Nikki. This is the slide about engagement. We have been engaging with service users and staff and members of the public, and on our website which you can see here, www.royalberkshire.nhs.uk, you will find a button which says Building Berkshire Together, which is the name of this project, as it were. And if you click on that button, it takes you into a microsite where you'll find more and more information about this project. So far, we've had well over 5,000 visitors to that site, and it is being constantly updated, and it will be updated further as we proceed from here. Chair, that concludes the presentation. So with your agreement, I'll hand back to you and hand back to Nikki. And I know Nikki and Andy Statham, our Director of Strategy, are both on the call, and I'm sure we'll be very happy to take calls from you or from members of the committee.
Right. Thank you, Nikki, and to John there. Thank you. I was going to call on Councillor Hoskin to speak on this.
Thank you, Chair, and thank you very much for coming along and giving us this presentation and updating us on what is an incredibly exciting opportunity. I mean, I think anybody who has, which is most people in Reading, anybody in Reading who's anything to do with the Royal Berkshire Hospital knows what wonderful service it provides, but also knows that it's well overdue in terms of new investment in facilities. You know, some parts of the hospital more than others, you know, clearly is required. So, you know, this is something that, you know, as a council, we're very pleased to support in principle and to be a partner with you in terms of getting the best possible outcomes for the people of Reading. It goes without saying, this is going to be a huge major infrastructure project for the town coming up, and therefore the first thing I'd like to say is, you know, is thanks for coming along, but to emphasise the element at the end, which was really pleasing to hear, and your assertion that you see an ongoing role of working with ourselves and obviously other local councillors, but ourselves in terms of the rest of your process you're going to be going through, and I would like to emphasise that we're very keen to be part of that. We're very keen to be involved and to represent the views and to, you know, provide some of that accountability backwards to the town, but very much so to work with you in terms of how any new project, whether it be in the town or on the outskirts of the town, would work. I've got a couple of questions, so it's great you've offered that. So I'm really interested in the process. This may actually be impossible to answer right at the moment, because I'm going to ask if you've got any idea really in terms of the next stages of the process, in terms of the timescales and the timetable. So, you know, you submitted to the Treasurer. I don't know if you've got any understanding of how long that's likely to take for them to be going through that process of considering your first stage, and then how quickly they're moving on to the subsequent parts, and particularly you know, you sort of said at that point you may start to then whittle down your options of where you want to go. So I'm quite interested in when you think that might work. Obviously, that'd be something that we'd be really interested in inputting to as a council. And it's also maybe very difficult. What are your expectations, you know, roughly in terms of when you may actually start to be working and developing, you know, the new services, you know, basically seeing building work and sort of an idea of what you may be hoping to be finished by. The other thing that I'm really interested in is what your view around minimising impact on current services. So obviously you're talking about major projects. So one of the things obviously we are really interested in is how, as well as the impact that would have on the local area of wherever this happens, but particularly from my point of view around health, how that might impact on services and where those services are throughout that period. I'm really interested in developing with you how your views around the project would fit into the ongoing strategy and vision for health and care services in Berkshire West, which partly is around services being closer to home and community-based services and solutions. So whether that fits within, you know, your project, how working with health and other health providers and social care providers and the voluntary sector, you know, about that being part of your plan. So I don't have very much more to say. I also have questions, and I also noticed you're coming along to our Health and Wellbeing Board on Friday. So, you know, if we have any more, we've got some, and that is great because we're really looking for this ongoing relationship of how this develops. So, yeah, no, thank you for this opportunity, and I'm sure others have got questions as well. Thank you.
Thank you, Councillor.
Madam Chair, can I ask Andy to respond to those points, please? Thank you.
Yeah, sure. Thanks, Councillor Hoskin. Thanks for the support that you've given on behalf of the council to date. I think I kind of answer the question about the stage of the process. So our assumption is that this next stage is going to take between 12 and 18 months. But there's a lot of dependency on quite how quickly the central government turns around their initial response and kind of gives us the permission to go. But in our minds, that we've got a 12 to 18 month window where we need to make that decision about where we're going to be located in partnership with all of our colleagues across Berkshire West, and then the build phase is probably even more constrained by the timings in Whitehall. So at the moment, the Health Infrastructure Programme has funded the Wave 1 participants, of which we're a Wave 2 participant, and has signalled that the funding for Wave 2 participants will come in the next spending review period. So that will all be driven by the timings of political cycles and spending reviews, which have been significantly impacted by the COVID pandemic. But I think we would be looking at a timescale of around 2025 to be in the new in some or all of the new facilities, depending on how that spending cycle plays out. Just thinking about the second, your third question about alignment with the plans of the health and care system in Berkshire West and beyond, I'd say absolutely the work that we've done to date in trying to understand the scale of the hospital that we might need into the future has been drawing on the plans that we've been developing together as a ICP, and we make some strong assumptions about what we're going to be able to deliver as a system in terms of driving care through digital channels, which COVID has been a really big enabler, and also in working with primary care networks to support their growth and the enablement of care into the community where it's clinically appropriate to do so. We hope that's going to have an effect on footfall, which I notice is one of the questions we've had on the chat, and should reduce some of the demand on the site, both from patients and from staff accessing the site. But I can't promise at all that's a silver bullet to some of the significant transport challenges we face in the centre of Reading. And just finally, the question about the impact on services. That's obviously one of the prime considerations that we've got to make, because we can't go a day where we're not providing our patients with the essential services they need. That's obviously much easier if we chose a Greenfield site, although that comes with a whole host of other operational and delivery challenges to get to. But we, in developing the drawings that John has summarised there, we absolutely have got a phasing plan that allows us to build a building in order to decant services from the next building and then knock that building down. And so we've done that spatial analysis of how we swing the hospital round in order to retain all the services that our patients need, whilst being in the middle of a building site.
Thank you for that, Andrew. I've had notification that Councillor Jones would like to ask a question.
Yes, thank you, Chair. First of all, just as a matter of detail, and I hope it's not nitpicking, your drawings or maps are inaccurate. And I think if you're going to do this kind of stuff, it would be good, I think, to make sure they're accurate. Addington Road does not cross Redlands Road. It appears to have a road junction there. It doesn't. So perhaps you could look at that. 4 points, if you'll allow, Chair, where you could say they're statements, but hopefully they will provoke some kind of response. The first one is around trends in healthcare and trying to pitch forward into the future. Some colleagues know that the Saturday before Christmas, I was invited to go to the Royal Berks for a hip replacement operation. And as one of the 2 councillors who have the hospital at the end of my street, I was able to walk there. And let me say to Nikki, perhaps you could pass this on, 4 weeks on, I'm now pain-free and able to mobilise and walk without crutches. So great success and thanks for all of that. But I've heard it said, well, we've learned a lot through COVID and, you know, we don't have to have all these kind of day visits from people to check up on things. It's amazing what we can do remotely. Tomorrow, I'm due to have a second physio assessment by phone. And I'm not sure physio assessments by phone are necessarily as good. So, I mean, I would just say, and I'm sure you don't do that, let's not kind of base future trends possibly on the kind of sharp arrangements or change in working practices we've all been forced to make through COVID. However, let me also say in terms of not being parochial. So there you are, somebody who's the Royal Berks at the end of my road. I don't believe we should be parochial. My understanding is that the catchment area, and as fond as we are in Reading to think that the Royal Berks is our hospital, the catchment area goes beyond the borough boundary. I think, is it something like 500,000 or 600,000 for acute services and 1 million people perhaps covered for specialist services? You know, far bigger than the borough boundary. So as much as in Reading we will speak on Reading residents' behalf, I mean, I do hope we can all lift our heads and be a bit more perhaps strategic on some of these things. And as the lead member for adult social care, I'm only too well aware, and thank you, Nikki, for your comments about the holiday and stuff, that the future means an ageing population, but with more complicated and challenging health and lifestyles for many people. So again, that kind of changes things. So if we're planning 20, 30 or 50 years ahead, it does seem to me that any reasonable analysis and conclusion is that all the options up to and including option 4 is not going to meet those kind of growth or integration ambitions that you have. So having set out 6 options for us, I mean, I think it's probably reasonable for us to discount the first 4 of them as not workable or not desirable in terms of our future needs. So if we move on to the case for change, and I was very interested with the 5 C's, and you know, not alarmed, but obviously concerned that one of the C's, capacity, we're already working beyond capacity. Can I suggest 2 more C's for you to consider? One being community, and I know, Nikki, you'll check your watch to see how long we've gone before I mention it. Congestion, and particularly parking. Community, by which I mean, this looks to me as a kind of 10-year plan of disruption for local residents, of noise and dust and everything else. If we go for option 5, particularly if you have a model of trying to cram more and more onto a very limited site where you demolish and move and then demolish and move and whatever, that to me doesn't seem on first reading as a particularly welcome approach. there was also some mention that I read or heard somewhere that you were looking at different kind of logistical things, including night deliveries. Well, let me tell you, night deliveries is a kind of issue we deal with Tesco superstores and would not be welcomed by local residents. So in embracing those kind of future logistical challenges, let me suggest to you that that isn't an option that probably is worth pursuing very far. So in terms of the community, I'd like you just to perhaps have put greater emphasis. I'm sure you're aware of the impact you have on the immediate local community, but perhaps if you could include that. But let me come to congestion. Outside of the town centre and the Oxford Road and Wokingham Road, Reading Council issues more parking tickets around the Royal Berks Hospital area, twice as many tickets as all the rest of Reading put together. And I think that's an indication of the frustration that I see, people perhaps coming to appointments or visitors trying to come to the hospital, just driving around and around trying to find somewhere to park and then deciding they're going to give up and park illegally or unlawfully or take a chance. That's been the case for years, but I think the evidence shows that that's not improving. And the more you cram onto the site, I would suggest to you that will only get worse. So as much as we can do to mitigate and help the Royal Berks with that, I would say that that really isn't an acceptable trend we should plan to live with in the future. So, and I have to say, particularly if we were to support you in your endeavours to chase a university hospital status, which I do hope would happen, perhaps we could look for examples elsewhere, say in Oxford, where they built, I remember the Radcliffe Infirmary in the middle of Oxford, and then the moving out to the Ring Road for the John Radcliffe, or the old hospital in the middle of Swindon, and then the new Great Western Hospital, or it's not new now, near the M4. I understand Basingstoke and Winchester are looking for a new hospital site on the M3. Is it in terms of a regional approach rather than a very parochial approach, and something which, again, we can't ignore, delivering as near a carbon neutral future as possible, that we should not look to redevelop where we are? My fear would be, if you try and redevelop, even option 5 talks about a complete rebuild, you will be forced to build upwards into the sky because you can't make the land footprint any bigger. And that in planning terms also would not be welcome. So if this is a once in a lifetime opportunity, I do hope that the Trust will not blow it and will not, through lack of ambition, perhaps chase an outcome that in the longer term for the real wide community it serves, at least actively and doggedly pursue option 6.
Thank you. Yeah, thank you, Councillor Jones. I haven't received any further indications from councillors, so can I ask if Nikki, John or Andrew would like to respond to the points raised?
Yeah, thank you. Quite a few points to pick up there, yeah. Councillor. If I can dodge around a little in the order in which I respond to those. Certainly, in terms of the environmental impact, you may be aware that we've been absolutely reviewing our travel and transport policy for today and now, and we're doing a lot of work in that regard, which is still underway. So because this is all happening a long time from now, immediately we've recognised the need to address our impact, and certainly we are investing heavily in upgrading our shower facilities, our changing facilities and our bicycle storage facilities, so that our colleagues have a much more attractive and available option to get to work via running or bicycle if they wish to do so, and know that there's adequate changing facilities around and storage facilities for their bikes. And you'll also, I'm sure, be aware of the work we've been doing with Reading buses, again part of the council, to make sure we've got very good bus links and regular cycles of buses coming between the train station and the centre of town and other areas that loop all day long to bring our staff onto site, which is already starting to address some of those concerns, but obviously we've still got a lot more work to do in that regard. In terms of the carbon neutral, we are, one of the design requirements of the HIP2 programme is carbon neutral, so it's embracing modern methods of construction and looking where possible to use the most environmentally sustainable solutions, both in the design and in the construction, to minimise environmental impact as far as it possibly can. So those are absolutely inbuilt and designed into any further stages, and they've been absolutely at the heart of our thinking up to this point also. In terms of the community, as you know, as an anchor institution, obviously the Reading Borough Council is also an anchor institution. We are our community, and the impact we have on households through our employees, through our staff, through our suppliers, our neighbours and our other stakeholders, it's wired into our DNA about community. So apologies if it hasn't appeared overtly as one of the 5 C's, which is the requirement that the Treasury, that's the model we're required to use when submitting cases to the Treasury. But please do be assured, Councillor and colleagues, that community is very much in our hearts and driving everything that we do, and in fact it underpins our whole vision as an organisation. So congestion again is an area we are addressing in the new designs, and one of the considerations, and certainly a theme that's come through on our microsite and through our engagement, is that absolute commitment to a sustainable solution. Colleagues will also be aware, given the demographics, and I know you look at these as well, we know that people are living longer with a number of health conditions, and we've already started rapid access care of the elderly clinics running, so that there's a one-stop shop, and indeed the clinical services strategy, which underpins all of our designs to create the right built environment for future health requirements, will be building all of that in, so that a generalist services as well as specialist services being catered for. And the other thing you mentioned around the catchment area, yes, we absolutely are a district general hospital. We also offer specialist services, and we also, as you may know, have a number of other sites we operate from. So we have premises that we rent on University of Reading White Knights campus, which is our early house children's service building. We also have 2 premises over at Windsor, which is the Windsor Dialysis Unit and the Prince Charles Eye Unit at Windsor. We have Bracknell Health Space, which again, we offer a number of services from there, as well as Townlands Hospital in Henley, and also West Berkshire Community Hospital. One of the things that we have been able to do through the pandemic is examine what services we can offer from where, and we're looking all the time as to what else can we move off-site and make sure we've got as wide as an access as possible, and good access for people to services near where they live. So certainly services like dialysis, cancer services, and a number of outpatient as well as diagnostic services are now offered from multiple sites rather than just the main Reading site. And our vision for the future is certainly not all of one or none of one. We know that the blended approach of offering face-to-face appointments as well as virtual appointments as well as phone appointments, and also you may be aware of our remote monitoring of patients. So again, old medical practice was we bring people back for outpatient appointments every 6 months, just to tell them they're okay. Sometimes because of remote access, remote monitoring now, we have thousands of patients across HIV, across multiple sclerosis, gastroenterology, and now dermatology, where patients with long-term and chronic conditions can be safely and clinically assuredly monitored without having to come into hospital if they don't need to, but knowing that their condition is being supervised safely, and if anything changes they can come in very quickly. So we're evolving with our clinicians how those services are being delivered, and we're continuing to evolve that through the design and planning stages, because it impacts on the amount of space we'll need to build and the sort of, as John mentioned in the slides, the adjacencies we'll require and how those services will be delivered. But please be assured, at the heart of all of this is our absolute commitment to keep engaging with our stakeholders to help shape the future designs and work with us to make sure we create a healthcare space that is fit for the future and delights our communities and our staff for many years to come.
Thank you, Nikki. So have we got any further comments from councillors? I'm sorry, was that somebody speaking there?
Sorry, I was just gonna add to Nikki's comments. So it was great to hear the example of the councillors' operation, and it's great to hear about the speedy recovery. Pass that on to Mr. Pollard and his team. It's just one example really for everybody about how our teams have been maintaining the elective care through this pandemic period, and the terrific efforts that all of the team have been putting in. I think on the technology side, you're absolutely right. You know, COVID's taught us a lot about what we can deliver on through digital platforms, but it's absolutely an extreme position. And it'll teach us many things, but also some things that we absolutely want to restore the face-to-face care where it's clinically appropriate and necessary. And that's, I just want to provide assurance that our assumptions about how big we need to build the hospital are not built on the current model of healthcare delivery we're having to deliver because of COVID.
Thank you, Andrew. Can I ask if any other councillors would like to speak on this subject?
Chair, if not, can I just come back very quickly then on a specific concern? I appreciate I made kind of more statements, tempting responses rather than direct questions. But I mean, my analysis is rule out all the first four. So if we're down to a complete rebuild as option 5 or a new build elsewhere as 6, on 5, how far have you been able to make any assessment whether, I've said cramming more onto the site, but let's just say concentrating more onto the current footprint, how far you may feel under some stress to build upwards, frankly, just to have some bigger, taller, higher blocks, because that's the conclusion I come to. I think that's the only way you would be able to do it. The plans you have look down, but and obviously this is not an advanced planning application, but my sense is that to accommodate all that you want to accommodate, you'd have to have some fairly significantly massive, and I mean in terms of massive buildings going upwards.
So you're right, a number of the buildings that we currently have and the level of the build are would need to increase as we do that, but a large number of our buildings are not actually that tall. So the buildings that we've got down on West Drive are only a single story, and the designers have paid some attention to the existing massing of the buildings on there and what they understand to be likely permitted development within that, and have taken that into account. So whilst there may be more taller buildings, as I looked at what they developed, that was within the current highest massing of some of the buildings that are on the site already. I think there's more detail that we can show and share as part of a follow-up conversation about designs that they've come up with so far.
Chair, thank you for that.
Thank you. Okay, I've received no further indications from councillors to speak. So can I just confirm no other councillors want to speak? No. Okay, I'd like to thank Nikki, John and Andrew for coming along this evening and providing us with all of this information, a really useful presentation. So thank you very much.
Thank you, and it's been a real pleasure to join you, and as always we look forward to continuing to engage with you over the coming weeks and months, and thank you again colleagues for all of your support. I'll leave the meeting now, if you'll excuse me please. I need to attend to a matter in the hospital, but thank you, and it's it's great to work with you. Thank you.
Thank you.
Thank you very much.
Yeah, thanks for coming along. Can I just confirm then, we obviously have no more indication to speak. Are we happy to note the presentation? Is everybody happy to note this presentation? Yeah.
Agreed.
Agreed? Yeah.
Agreed.
Thank you. Thank you. So moving on to agenda item number 8, which is the future commissioning of the NHS hydrotherapy services in Berkshire West. We are joined this evening by Maureen McCartney, Sheraz Claridge and Dr. Kajal Patel, who will be giving a presentation on the future commissioning of NHS hydrotherapy services in Berkshire West. Maureen McCartney is the Director of Operations, Reading Localities and CCG Director Lead for Urgent Care, and Sheraz Claridge is Operations Manager for Newbury Locality, and they're also joined by Dr. Kajal Patel. So I'll hand you over to Maureen, I understand. Thank you.
Thank you, Chair. I'd just like to come in there. Maureen is watching the live streaming. Unfortunately, she hasn't managed to get in, but Dr. Patel and myself were mainly doing the presentation today. Anyway, so we've had a few technical issues, so forgive us for that.
No, that's all right.
I'm just waiting for Dr. Patel to join us. I'm presuming she's just trying to unmute.
Hi.
And we're on.
Hopefully you can see me.
Yes, we can now.
Brilliant. So my name's Kajal Patel and I'm one of the GPs at Millman and Kennet Road Practice, and our practice serves 20,000 patients. I'm also the GP clinical lead for Reading. Within that role for the CCG, I'm also the Berkshire West Cancer GP clinical lead as well. So that's a little bit about me. I'll hand you over to Sheraz.
So I'm Sheraz Claridge. As you said, I'm the Director of Operations for Newbury Locality, but I'm also the Director of Operations for Planned Care, which is the reason I'm here presenting with Dr. Patel as well. So we're doing a dual presentation, so we're sort of in and out. I'll hand back to Kajal, who's going to start.
Okay, so I'm presuming that members will have read the details of the papers that were submitted by the team, and what I'm going to do is provide a succinct summary just to recap, and then we'll take questions. So the NHS Berkshire West CCG approved revised arrangements for the commissioning of NHS hydrotherapy services in Berkshire West. What this means is that the hydrotherapy will be funded when exceptionality can be demonstrated via an individual funding request, which considers an individual's needs and benefits. Given the operational challenges of providing this service, currently due to stringent infection control policies, the CCG will be working closely with the Royal Berkshire Foundation Trust to determine the best way to provide this service going forwards. Hydrotherapy is special exercises completed with a therapist in a pool heated to a higher temperature than a typical swimming pool. It's prescribed as a specialist treatment for a number of health conditions, including musculoskeletal and neurological conditions. The hydrotherapy facility at the Royal Berks Hospital has been closed since March 2020 as part of the Trust COVID-19 infection control policy. Now, the CCG has a duty to continually ensure limited NHS resources are spent prudently and that the services it commissions are evidence-based and they offer clinical benefit to the maximum number of people. The CCG for this will regularly review procedures of limited clinical value. Procedures where the clinical effectiveness of that procedure is either absent or evidence shows weak efficacy. Hand you over to Sheroz now.
So I'll just run through some of the high-level information about the consultation. So we decided to run a consultation to gain opinion and understand the different perspectives in order to inform a decision on the future provision of this service. This is the first time there has been a public consultation undertaken about this issue. And the scope of the consultation was related solely to the hydrotherapy services for NHS funded patients, those referred by a physiotherapist or a consultant from Royal Berks Foundation Trust using the NHS funding from the CCG. Just to be clear, the consultation scope did not include hydrotherapy services funded by local authorities and commissioned from other agencies, including schools. It also did not cover all activities that operate from the Royal Berks pool, as many other agencies utilise the pool through non-NHS arrangements. The consultation commenced on the 10th of August 2020 and concluded on the 2nd of November 2020, running for 12 weeks. There were challenges because it was in the period of COVID, so we made sure that we had multiple ways of accessing eliciting information and responses. So we utilised online surveys, hard copies of the survey, had a dedicated inbox for detailed responses, and also virtual stakeholder meetings. The CCG received positive responses to the survey. We had around 498 individual responses, as well as 9 written organisational responses. Of this, just to be clear, 217 identified as having used the NHS service and 279 had not. Only 59 identified as being NHS patients who had been prescribed hydrotherapy. There were a vast number of comments related to the future of the pool at Royal Berks rather than the provision of hydrotherapy more generally. And it was evident that these comments came from residents who utilise the pool in a private capacity. Other general themes included a view that hydrotherapy doesn't have to be provided at a hospital site. A better pool was required and hydrotherapy was really beneficial to aid pain relief. So I'll hand back to Dr. Patel, who summarised the decision that was made and the thoughts behind it.
So when we looked at the evidence, there is a limited amount of good quality evidence on the clinical effectiveness of essentially hydrotherapy or physiotherapy in water versus land-based therapy. And therefore, considering the clinical effectiveness and analysis of responses to the public consultation, the CCG governing body members approved an option to commission hydrotherapy services based on an exceptionality basis via an individual funding request. This option allows the consideration of the individual's need and assessment of benefits that hydrotherapy could deliver against a set list of clinical criteria. These criteria are being developed in partnership with the Chartered Society of Physiotherapists. I'm going to end the summary here so that we can spend some time on any questions that you have. Thank you.
Thank you for that presentation there. We have also present this evening and speaking to the item is Ian Croker from the Chartered Society of Physiotherapy. He's the organising officer. Is Ian available? Ian Croker. It's just gonna.
Chair, it's Richard here. It doesn't look as though he's joined the meeting, and I've not heard from him at all.
Oh, okay. I do apologise. So I thought it was here. Okay, thank you. In that case, Councillor Hoskins, you indicated that you'd like to speak on this, and then we can see if any of the councillors would like to raise questions.
Thank you, Chair. I've just actually received an email from Mr. Croker saying he's sort of on the Teams meeting, but he doesn't seem to be able to speak. So I'm not sure if he's joined as a member of the public as opposed to sort of, you know, within the meeting. But he has given me. Am I able to read his key points out actually? Which
you are, yeah.
Yeah, spent the time to read. I'm going to read them verbatim. In fact, let me see the easiest way to proceed. So, Mr. Croker, sorry, I'm just battling with my Mr. Croker, who, as we've said, is from the Chartered Society of Physiotherapy, has these key points. He says, except that the pool at the Royal Berkshire Hospital may not be fit for purpose at present, but if a decision is made to close it, then a suitable alternative provision must be found. In other words, he's saying that, you know, Reed does believe it should continue. There is evidence to support aquatic physiotherapy, hydrotherapy, in a number of conditions, however, none of which is linked to NICE guidance, except in management of axiospondylitis, which is why the commissioning group wants to move aquatic physio to procedure of limited clinical benefit and develop an individual funding request process. Most procedures of limited clinical benefit of specific conditions where as AP, aquatic physio, covers a wide range of symptoms and conditions such as rheumatological, neurological, musculoskeletal, paediatric and pain conditions. It is appropriate to consider it as procedure of limited clinical benefit. APO has been hydrotherapy, by its nature, facilitates an improvement in function in some of the most disabled members of society. Buoyancy counteracts the effects of gravity, and floating allows for freedom of movement. A seizing or restriction of access to hydrotherapy may promote further health inequalities for these people, as they're not able to achieve the same or similar levels of function on land. The IFR processes, by their nature, about restricting access, and referring clinicians have to prove that the individual patient has a need over and above others with a similar condition. Funding is only provided on an exceptional basis, again promoting further inequalities. CSP, which is
Chartered Society of Physiotherapy.
Yes, sorry, of course it is.
Yeah, sorry.
That's quite obvious, isn't it? Sorry, so many acronyms for.
We love our acronyms, don't we? Yes. Yes.
Sorry, CSP are working with the commissioning team to try and influence the development of the IFR process to minimise the restriction of access, but it seems the moving away from a referral open access has been decided by the CCG. Appreciate that this is also a cost-saving exercise by the CCG in order to gain the most benefit for a wide range of patients with limited funding available. However, this has consideration been given to increasing activity within the pool at the Royal Berkshire Hospital in order to offset the maintenance costs, etc. And then access to hydrotherapy allows individuals to self-manage their conditions, thus saving costs on hospital GP attendances. And hydrotherapy will be an effective treatment option for those with multiple morbidities, recovering from COVID and with long COVID, as supports graded increase in function, muscle power and stamina, while reducing pain levels and the need for pain medications. So that is that okay to sort of say that's Ian Croker's contribution to the meeting. I don't know if the people here have any, would like to respond to the points raised. And then we're okay, Ruth, if I then come
yes.
back on that. Okay, thank you.
I'm happy to pick up some of those points, Chair.
Yeah, please do. Yeah. Thank you.
So just there's quite a lot of points there, so I'll pick some high level points there because we've been having conversations with Jane Mitchell from the Chartered Society of Physiotherapy, so I'll refer to them as CSP, and they've raised all these points with us, and they raised this because our governing body was public as well. So really appreciate around the information that they're providing around the evidence. But if I draw you to the paper that we've got, which looked at the evidence, that there's a hierarchy of evidence that's utilised when you look at services, and randomised controlled trials of hydrotherapy compared with land-based physiotherapy show no difference in effectiveness on outcomes of function and pain for patients with osteoarthritis,
idiopathic arthritis, rheumatoid arthritis, asthma, back pain, fibromyalgia, haemophilia, Parkinson's disease, or rehab following stroke. However, what has been mentioned, the ankylosing spondylitis and some of the other conditions, there is limited evidence, or what we call anecdotal evidence, which is why we have said that we will work with the Chartered Society of Physiotherapists around developing these clinical criteria. And also we are working with the Aquatic Physio Society as well, developing. So we've taken that on board. There were a few comments about the pool. The funding of the pool is not within the funding that the CCG provide. So we don't have a lot of details around the cost. We do know there's been maintenance issues over a long period of time. We might have some questions about how much of this service is part of physiotherapy. So we commission physiotherapy as a block from the hospital, and hydrotherapy is part of that whole physiotherapy block. So if I give you an idea of figures, about 107,000 appointments are for physiotherapy within a year, and 1,800 or 1.6% represent hydrotherapy. And that's approximately about 300 patients. So you can see that the size of what's commissioned and what's provided. And then there was also mention about long COVID. So we do have long COVID, post-COVID assessment clinics in place at the moment, which are developed around MDTs, which is physiotherapy, which is also cardiac, respiratory, as well as psychology. So that is always developing, and we're having ongoing conversations around what that looks like going forward, because that is, as you will appreciate, quite a new subject matter that is building in our knowledge. So I'm hoping I've picked up some of the points. I did try to make a note. I might have missed some, so apologies for that. There was quite a lot there.
Thank you. Thank you for that. Councillor Hoskins, did you want to come back? Because I know you wanted to speak as well.
Yeah, thank you. I mean,
yeah.
Well, I'll say briefly. I mean, I've got a few points to make. I mean, I think thank you very much for coming along tonight and outlining sort of the rationale for your decision. I think there's two things. One is you would expect us as a council to disagree with your decision. I mean, in October, the full council, when it met as together, unanimously agreed that the decision to withdraw the funding from the CCG for the hydrotherapy block was the wrong one, was premature in terms of the point in time we have, and that relates, I think, to some of the points around long COVID and understanding the health situation, I think, as we come out. I think it's also worth saying that the council response, which disagreed with what was then the proposal, were very much included whilst that was the full council, the elected politicians. The council response was also very much included the views of our social care professionals, who see in terms of the range of people that they're involved in, the clients in various different groups, the real benefit of hydrotherapy. And whilst that is from a range of forms of access rather than just that which is provided and funded by the CCG, I think it's worth emphasising that this change may well really force the sort of the death knell of the pool. It's been under threat over and over again, from whence it was from Battle to move to the Royal Berkshire Hospital. I think it's no secret that that it is a facility under threat. It's had some issues and some problems, and I think there's a real danger that this decision could end that provision of any kind of hydrotherapy in Reading, simply because, simply in terms of the sustainability of that pool when we get to the stage where it could be used again. I think to sum up my concerns, I mean, I think the CSP have provided some really good input. I think to sum up my concerns, I feel that the the lived experience of lots of people who have benefited from hydrotherapy and have lived that experience of how it's supported them to be to maintain their independence, to maintain their health and well-being, and to stay well. I feel that that's not necessarily been listened to as strongly as it might do. I think it comes over very strongly in terms of the survey, less so in terms of the report, which I think does rely very much on some of that hard evidence. I do understand the difficult situation that our local health, the CCG, our health commissioners, people who plan and provide healthcare, are under. I remember the business plan, or if it's called that, was facing this was before the COVID crisis, was facing a £20 million shortfall in terms of providing the the services that they'd like to do for Berkshire West, and that's a considerable sum of money. So I do understand that it's difficult to provide the health services that they would like to provide when they're facing an underfunding situation. It's been going on for some years and is still there. But I do feel that this is a decision that really could affect people who are most in need of our support, that it could in fact turn out to be a bit of a misplaced saving in that it doesn't really take into account, I believe, the preventative nature of the hydrotherapy service in supporting people to stay well and healthy, and can then lead to bigger impacts on public finances down the line. And I think it's also the other concern I really do have is that the process of only the exceptional case process, I think I have a real worry that will mean that a lot of people that might most need it won't end up being put through that process. It may be the sharp-elbowed middle classes may push their way to the front of the queue and perhaps secure that occasionally, if the hydrotherapy pool continues to exist. But actually, there will be an inequality in access from that point of view. So I think those are my concerns. I mean, I realise that and appreciate that our NHS colleagues have come here to explain it. I think to sum up the debate that we had at Council in October, and I say it was unanimous from the different parties, is a real desire that hydrotherapy can continue to be provided to the people of Reading into the future, and I really worry that this decision may make that possibility much less likely. Thank you, Chair.
Thank you, Councillor Hoskin.
Do you want me to make any comments at this stage?
Yes, you can do, Dr. Patel. Thank you.
So thank you for those comments. So in terms of getting down to the evidence that where it can be clinically effective and the criteria that will be developed in partnership with the Chartered Society of Physiotherapists, I think that hopefully will give you some reassurance when that is done, that the people that will need it, where the evidence can show that anecdotal evidence where it can help, will hopefully give you some reassurance from that. I think in terms of the exceptionality, in terms of the numbers as well that are actually accessing it, 400 or so compared to the actual wider use of physiotherapy, it may be that we just need to see how that works in terms of accessing it. And being the Reading GP locality, absolutely, I work in one of the practices that has 3 of the most deprived wards, so I would not want there to be any inequity in terms of accessing the service.
Could I come in as well, Chair? Thank you. Sorry. Thank you, Graham. I feel your response was very balanced, actually, because you understand the financial position. But I want to be really clear that actually we did take on board the consultation, and that decision is based on the information that was in the consultation from patients that did reflect their benefits. But I also want to be clear that there are 2 types of hydrotherapy access that's being talked about, and that's why I was very clear about the scope. So some of the well-being elements that you're talking about may apply to some of the services that are being used by non-NHS funded services and the voluntary sector compared to what is used for NHS funded. So I do want to be clear, there are two types of services that utilise the pool, and I won't reiterate that, but I think, you know, just to make that point, but we did reflect that, and the decisions that has been made mitigates some of the elements that were reflected in the consultation that was provided, you know, which is why there's the decision around basing it on clinical criteria, making sure that the patients who most benefit from it and have the needs will gain that access. And I understand there are reservations about that, but we are, you know, we're working very closely with our clinical effectiveness team as well as the CSP to move this forward. Regarding the pool under threat, those discussions are ongoing at the moment. You know, we will be working with Raw Barks, as was said, to move this forward. But if we are looking at local pools, we had some people who joined our public governing body, and they've offered to support us with looking for other avenues if need be, for what we call spot purchasing as well. So there are options available out there. So I just wanted to provide some assurance around the concerns that you've raised, that this is not just a sort of one-dimensional. Have taken on board all the comments that we've had, because we had a very good response, and I wanted to make that reflected back in there. And just to pick up a final point you mentioned about the social care aspect, again, by having these clinical criteria, it will make sure that the patients that benefit the most will get the access that they require. Thank you, Chair.
Thank you to both of you. I've received a notification that Councillor Terry would like to speak, and also I can see that Ian Croker's here now. But Councillor Terry, would you like to speak first? Then we'll hand over to Ian Croker. Is that okay?
Thank you. I just wanted to reflect. This is in effect our scrutiny item, and I respect the fact that the Berkshire West CCG representatives, sorry, I can't quite see your name, so apologise for that. You know, made their case, and I think from your position, I understand what you're saying in terms of, you know, all of us in public service know that what we spend most of our time doing is rationing resources, because there simply isn't enough funding and resources to go around. So I don't think we want to be critical about the way in which you've reached your decision. Nonetheless, as you've said yourself, there are two exceptions. One is that there are some cases where there's clinical evidence that hydrotherapy would be useful, and therefore you've created an access route for that. And secondly, there are the others, you say voluntary sector and other users of it, who have found that it helps their well-being, whether or not that's clinically supported or not. The problem, I think, for us as ACE committee and scrutinising, you know, looking at our sort of general health responsibilities and well-being of the community, is that, you know, we see it ourselves, we know how it works, is that we make our decisions based on our own budgets and criteria that chip away at a resource that's somewhere else, which eventually means that it goes. And then none of us have the access to it that we want to retain, because actually everybody sort of dips out because they can't afford to make their contribution anymore, for all the good reasons that you said. So my point being is to support everything that Councillor Hoskin has said, and to say, I think, though, as the ACE committee, we might want to sort of agree that I think the colleagues from Royal Berks mostly have gone now, but perhaps to our staff, the director is here for adult social care, for example, that we need to hold on to this and say, we need to be careful we don't lose a resource that we do actually need in many other respects, unnecessarily, simply because we can't, or because we've all had to make individual decisions based on our own evidence about why we might limit or restrict access to it based on certain criteria. You get my point, don't you? Is that we can all agree with each other about the fact there's limited resources, but when it's gone, it's gone. Now, what we heard earlier is that, if there's going to be a redevelopment or a new hospital for Reading, what we need to argue for is that it needs to think about whether it can provide this service ongoing, and if it's not going to, what's going to happen. So I think it just creates a really important point really here that we're concerned that your reduction in funding, for the reasons you said, whilst we might understand it, our concern is it's another nail in the for this service, and we need to take it somewhere else. So I haven't got the right wording in my head, Chair, so I apologise, but I think we might need to agree that we need to ask someone to hold the ring on this and say that we can't just lose this service by accident. We need to find a way in which we're having a strategic discussion about all the different sorts of access that they might be needed, including the Chartered Society representations, and make sure it doesn't get lost in the big picture of the new development, or in the difficult picture of all of us trying to work out how to manage our budgets. Thank you, Chair.
Thank you, Councillor Terry. I've got Ian Quirker now, who's from the Chartered Society of Physiotherapy, as the organising officer. Councillor Hoskins, where's some of your issues? But if you'd like to speak now.
Yeah, thank you so much. I'll keep it brief. I have been here right from the start, so thank you, Chair, councillors, and I've found the correct way in. I wasn't able to speak before, but Councillor Hoskin and Councillor Terry really covered my points very, very well. I just wanted to mention a couple of other points that. I think there's not been enough talk about the equality impact and the fact that some of our most disabled members of society depend on this service. By their nature, IFR requests about restricting access as need has to be proven over other people with a similar condition, which I just think promotes further inequalities. I think there could be a false economy here that without AP, it could lead to a deterioration in condition, leading to costlier treatment further down the line. And I do, without appearing cynical, I do feel that IFR, individual funding requests, will lead to, of course, it will lead to less use. Therefore, individual treatment costs will rise, and then I can foresee this facility being closed due to a lack of financial viability. And I echo what the councillors have said, having heard the very interesting and welcome news of the redevelopment of the hospital, that we need to think about the provision, whether it's going to be within the hospital or whether you can provide suitable facilities elsewhere. And I will also reiterate what my friends from the CCG said, that we really do want to work with you closely at the Chartered Society of Physiotherapy, but it's our patient need that is at the forefront of our minds. Thank you.
Thank you, Ian. I don't have any other notifications for anybody that would like to speak on this. Can I just double check and see if anybody would like to speak? No? Okay. Well, thank you to Shiraz and Dr. Patel and Ian for coming along and speaking on this item this evening. So can I just double check with members that councillors are all happy to note the recommended action and the report?
Agree.
Okay, thank you. Again, thank you for the speakers coming along this evening.
Thank you very much as well, and thank you to the Count Committee. We'll leave you for the rest of your meeting now. Thank you very much.
Thank you. Good evening.
Chair, sorry, there was just a question from Councillor O'Connell in the chat. I don't know if you saw it. I don't know.
I've literally just seen it now. I am so sorry. There is a question.
I don't know if the speakers are still here.
I'm still here from the CSP. I can attempt to answer that a little bit.
Can you see the question, or do you want me to read it out?
Sorry, I didn't check that. I'm so sorry. It's something maybe we can. I'm guessing Dr. Patel and Joyce have gone now to ask if there's can I ask if this is national policy? Are all CCGs shutting their hydrotherapy pools? Sorry, Ian, are you able to respond to that?
Yeah, it's not a national policy. I would say it's a trend. I have seen it happen in other trusts because, for a variety of reasons. Although I have seen some more imaginative thinking in other trusts. I'm thinking of, say, Ashford and St Peter's, Woking, just down the road, where they have they're using pools in a private gym. and it's a fantastic relationship between the trust and the gym, which have outsourced facilities to the gym. It's a Riverbourne gym, and it completely changes the dynamic of going to a private gym for treatment rather than going to a hospital. It's just so much more positive for the patient, and frankly the gym couldn't do enough for the trust. They work really well together. So I'd like to see some more examples of that kind of imaginative thinking, because we understand the pool might not be fit for purpose anymore, but I would imagine within Reading, I mean, look, you're developing a huge new Reading leisure centre, aren't you? There must be lots of opportunities to find suitable alternative provision.
Thank you. Thank you for that, Ian. And Councillor O'Connell, I apologise, I didn't see that message there. So if there's any more information required, we can ensure that it gets to you. Okay, so just following on, then everybody's in agreement that with the report, the recommended action. So if we move on now to agenda item 9, and so we have a report. Kate Reynolds is going to present the report for us this evening. It's the schools admissions arrangement for 2022 to 2023.
Thank you very much, Chair. This report is the annual report that we have to bring to this committee in order to enable the council to carry out its statutory duties in relation to admissions. The report has 2 elements to it. Firstly, to ask the committee to agree the determination of admissions arrangements for community primary schools, the coordinated scheme for primary and junior schools, the coordinated scheme for secondary schools, relevant areas and catchments for the academic year beginning in September 2022. That enables us, of course, to do the work behind the scenes to actually tell parents about the policy and how their children are admitted to schools and go through that particular process. The only changes we are proposing to committee for September 2022 at the moment are the dates that we need to change, because of course it is a different calendar year. Everything else is remaining the same. The second element to our report is to for the committee to note and to agree that if the current amendment to the admissions code of practice, which is currently going through Parliament, is passed, and if there are significant changes to local authority admissions policies, which we expect there to be, particularly around the issues of domestic violence and children in need, that we bring back a further report to ACE in March to deal with those particular outcomes, and also that we are currently conducting an internal review of SEND provision, including admission arrangements into our mainstream schools. And if that internal review shows that we again need to make changes to admission arrangements for September 2022, we would like to bring that back to the committee as well. So that's really what that report contains. I have on hand for you Victoria Hannington, who is our excellent admissions organiser within Brighter Futures for Children and does a superb job. And if there are technical questions you wish to ask about the report, please direct them to her. Thank you, Chair.
Thank you, Kate. Can I ask Councillor Pearce to speak on this report? Yeah.
To what Kate Reynolds just said, this is the first part is largely procedural, very minimal change, and then it's just mentioned the latter 2 we await the government changes and our SEN review to see what we can do in future. So not too much from me.
Okay, thank you, Councillor Pearce. So I'm checking the chat box now, and I can't see if there's any other questions from councillors, from members. No. In that case, are we all in agreement with the recommended action and to agree the report?
Agreed. Agreed.
Great. Thank you very much. Thank you, Kate. Thank you.
Thank you, Chair.
Thank you. So moving on now to agenda item 10, which is the adult social care response to the COVID pandemic. And so we have, let's have a look who's presenting this. Sorry, apologies for that. We have Melissa Wise is presenting this.
Thanks, Chair. Melissa's going to do it. It's her work.
Thank you, Chair. And I just wanted to say before we start, I wanted to thank the committee for the opportunity and space on the agenda this evening to allow me to share with you just for a short time the work that's been underway within the adult social care teams within the council during the pandemic. But that will naturally showcase some of the work of our wider partners in the council and externally. Next slide, please. So any presentation about the pandemic really needs to start with some of the context around the numbers. So I'm just going to start there, if I may. Next slide, please. So this first slide, and apologies, it's quite small, but really the significance is to show you the trend of the prevalence of COVID-19 over a period of time. So this actually shows the numbers per 100,000 in the population, and the Reading line is in blue. And really what this shows is that the case numbers have increased significantly during December and January, which has been in line with the regional and national trends that we'll all be reading about. However, it's also worth noting that in the last couple of weeks, we have gone slightly beyond what you'd expect the average to be across the southeast and the national picture in terms of prevalence. So you can see we're higher than the others. Next slide, please. So just really emphasising that, and it just presents the data in a slightly different way, but to show on that top row, what you're seeing is the number of new cases per week. And really what this is showing is over the last 3 weeks of complete data, we have seen a steady increase. And on the 10th of January, that week was 1,219 unique new cases of actual Reading residents that were deemed positive for COVID. Next slide, please. Sadly, this slide shows that picture around the impact that COVID has had on death rates. And the bars are showing, again, the rate of deaths per 100,000 throughout the pandemic when we started measuring in this way. And the blue ones are the ones that are directly attributed to COVID. And what you can see on the grey line is what the death rate normally looks like in Reading over that period of time. So whilst you can see in wave 1 of the pandemic, so April, May time, there was a notable increase in death rates above what was expected normally, and you can see the COVID element of that. However, in recent months, it has become more settled and back actually below what we'd normally expect to see in terms of death rates. What you can see right on the far right, though, the edge, is that we're now starting to see that increase above what we've seen, and we're potentially looking at some more deaths over the coming weeks just due to the second wave. Next slide, please. This slide, really, I just wanted to outline a couple of figures. So on the top row, on the right hand side, you can see that in Reading there have been 218 deaths in total that are directly attributed to COVID. And further down that row, that is overall 27% higher in terms of death rates than we'd normally expect to see in Reading. And at the bottom there, you can see that distribution of where people passed away, and that is a fairly typical picture nationally, although it's worth noting in Reading, we compare more favourably to some of our neighbours in the numbers of deaths that were experienced in care homes. Next slide, please. So now on to the role that we played in adult social care during COVID, and I'm just going to cover these 4 key areas. So looking at the support for our service users, for our hospital, the provider market, and then for our staff. Next slide, please. So from our perspective, we are a critical service supporting vulnerable people, which needed to continue albeit in a flexible way. So that first point is really outlining that that's exactly what we did. We looked at different ways to deliver our services using technology and virtual assessments, if need be, to continue with our work. And the average support that we provide per year is about 1,800 people are supported by adult social care in Reading, and 570 carers on top of that. So that just gives you a flavour of the numbers. And that generates about 600 unique pieces of work per month for us to manage. So during that time, we managed to continue with our support for vulnerable people, and that also included maintaining our internal services. So we have some very well used internal services. So we offer an overnight service for people with learning disabilities, a day service for people with learning disabilities, and a day service for people, older people with dementia. And once guidance allowed us to reopen these services, we continue to operate. Because what we tend to do with our in-house services is we support some of our most vulnerable in Reading, and those services were absolutely relied upon by our carers. So it was imperative that we got those up and running as quickly as possible. The next element talks about those that were deemed clinically extremely vulnerable, which was a new cohort of people that we were required to support. And people were deemed clinically vulnerable if they were seen as high risk of severe illness as a result of coronavirus. And that was determined by GPs and clinicians. And in Reading, that's 6,000 people that are deemed clinically vulnerable, and 350 of those were known to adult social care already. So we needed to take a new role in making sure those people were contacted, they were understanding of what was available to them, and where to go for help if they needed it. The next element is about working proactively with providers. So whilst we have our understanding of the individual situations, our providers who are going into people's homes are our eyes and ears. So what was really important was understanding from them who were the most vulnerable of our service users, that if we couldn't get care to them, whatever circumstance, we would need to put robust contingencies in place, and that's 200 people for us in Reading. And then the final point on that side is the benefit of teamwork, and some of the biggest teamwork we've completed is with our housing colleagues and minor adaptations colleagues, who go out and provide really essential equipment for people to enable them to remain at home. So since the pandemic, we've undertaken 18 big grant changes in terms of people's houses going in and making adaptations, which could be boilers, it could be flooring, just so they can live at home. And we've also installed 1,000 pieces of kit just to keep people at home. Next slide, please. So the next element of our role has been how we've supported hospitals. And they have really felt the impact of the pandemic, and notably Nikki and colleagues mentioned it earlier on. But some of our role in that is how we've helped to manage that flow both into and out of hospital. So one of the first things that we need to do is to support people to not go in, so avoid those hospital admissions in the first place. And that is our role, to identify people early where they may be going into crisis. And that could be, for an example, about putting in replacement services so that avoids any carer breakdown before it even happens, so therefore thus avoiding a hospital stay. The next element is fast tracking people out. So we know it's key to get people out of hospital as quickly as possible, ideally to their home environment, to free up hospital beds and to aid recovery. And one of the ways that we did that is to increase capacity in our hospital teams. So we've front loaded our teams to make sure we're there and ready to take people out as quickly as possible. And the final element there is the number of new packages of care that we've put in place since the pandemic to get people out and into their home, and that's been over 200 since the pandemic started. Next slide, please. So one of the other areas that we've needed to do is to find a safe place for people when they come out of hospital if they can't go home. So we've set up 2 new services during the pandemic to manage that. The first one is in Riverview Care Home, which is a nursing home that we work closely with. And this block of beds is for people who actually are likely to need some kind of nursing home in the future, that in ordinary circumstances would stay in hospital until they were able to come home, go to a care home, but actually we needed to get people out. So we found a safe place for people to go in the care home. So 67 people have stayed in that service since it started, and has, as I said, provided a safe environment for people to go to from hospital. We also have therapies going into that service to make sure that people are supported to be as independent as possible and enable us to make a good decision about where they're going to go in the future. Next slide, please. The other element, the other side of the service, is the Holiday Inn service, which Nikki referenced. And we have mobilised this service twice now. So we got it up and running in April for the first time, and then again in January of this year. So we have 20 rooms at the Holiday Inn in South Reading. We've put in their equipment so people can move around and they're mobilised, and also there are support carers on site 24/7 to keep people safe. And so far we have supported 19 people in that service. We've been running just over 2 weeks, and that saved over 90 bed days in hospital. So that's the equivalent, and that's been the impact therefore felt by the hospital. And in the first wave, it was 162 bed days we saved. Next slide, please. And I guess without wanting to labour the point really, and I can see that this is a busy slide, but I just really wanted to show you some of the comments from staff around this. And we are truly, truly proud of this work in Reading. We have led the way in this model and genuinely created something different to support the hospital with the challenges of people that couldn't go home. And it's open to residents from the neighbouring boroughs also, because this time we did it on a Berkshire West basis to really help the system. And this is now something that you might have seen yourself on the news. There's lots of talk about care hotels, and a number of authorities have contacted Reading so we can share our best practice about how we set this up. And this really is partnership working at its best. Next slide, please. The third element of our offer really in adult social care is how we've supported our providers. And when I think about partnership working, that is really key here, and that acknowledgement of the amazing work that our care homes and care agencies have done to keep people safe during the pandemic. And one of our key roles in this was to maintain that communication with those providers and provide them with timely updates when it made sense to them. Earlier on in the pandemic, things were changing daily around guidance. There was new developments around the use of personal protective equipment, PPE, and we needed to keep them abreast of these changes without them all needing to individually try and sift through the mounds and mounds of information that was coming their way at a time when we needed them to be critically delivering care. So that's been a critical role for us in adult social care, maintaining that dialogue and enabling us to respond to any issues, for example, around outbreaks as early as possible. The next thing we did was we undertook a council-led recruitment campaign on behalf of the market. The care market is notoriously difficult in terms of recruitment. It suffered well before the pandemic, but it became very acute during the first wave. And our role in this was really using various elements of media to try and harness those messages around actually being in care makes a really big difference to people. and also dispelling some of those myths about what people need to do if they worked in care. Another key element was providing the financial support to allow these providers to be sustainable. It's a challenging time to be a provider during the pandemic. There's lots of increased costs around equipment, staffing, and also reduction of numbers of people using the service. A lot of people were fearful of using social care services and found alternative solutions. But also, as I referenced earlier, we also had a number of people sadly passed away. So there have been some grants that have been given to providers, which we have passported across to the tune of about £2 million. But in addition to that, we've offered additional resilience payments to those providers that are really at the brink of provider failure, but also undertaken some advanced payments for people to allow them to manage their cash flow. The next element there is about personal equipment, so masks, gloves and aprons. And very early on in the pandemic, quite frighteningly for a lot of us, it was very difficult to come by the equipment, and there were real concerns about shortage. So we played a key role in really understanding the flow of equipment available to providers and then supporting them on an emergency basis if they were really struggling. And certainly in the early part of the pandemic, we were providing a huge amount of PPE, totaling about 50,000 pieces in total to keep the services going. Thankfully now that's managed by a central portal and the availability is fine. And then the final point on this slide was about partnership working, and I've just mentioned about outbreak management, and that's a scary time for a provider when they have an outbreak of COVID in their home or their service. So we've worked really proactively with our health colleagues around infection control training to really help rebuild the confidence of those services and reflect on any lessons learned. Next slide, please. So the next element, just to cover quickly, is around testing. And I think this time last year, none of us in adult social care felt could even imagine that we'd be needing to grasp some of these new concepts around testing for COVID-19. But it's been a really big area for us, and we've played, again, a key role. And thanks to Berkshire Healthcare Foundation Trust, back in Easter last year, we were able to support early testing of some of our providers and their families around ensuring that we understood their COVID status. And that was really important based on a reduction of spread perspective, but also about getting people back to work early, because at that point, without testing, people were needed to isolate for their full 14 days. Thankfully now, testing's become a bit more available, which has been helpful, but we were involved in a testing pilot back in October of mobilising testing in different settings. So we had a test in extra care and supported living settings, which is different to care homes, and domiciliary care, which is in people's home. So we needed to test what that looked like, and we were involved in a national pilot. We spend a lot of our time managing queries around testing, and to give you a sense of the volume, the national testing regime is in place, and that requires providers to test at least weekly or twice weekly for some staff, and in Reading alone that is 3,500 staff per week that need to be tested twice. So the volume and the administration in that is huge. Next slide, please. Another new area for us, which is providing huge hope during this challenging times, is the vaccination. So whilst we have been so pleased to be able to play a role in this, it's also created some additional administration for providers that are very, very busy at this time. So for us, again, we were able to provide early access to vaccine back in December, when our health colleagues managed to secure an earlier batch of the Pfizer vaccine. So very quickly before Christmas, we were able to have 150 staff in our system vaccinated. Vaccinations are now being offered to all health and social care staff in line with nationally set prioritisation, and thus far we've had about 600 staff vaccinated across the service. But to note, there is a huge amount of coordination and communication involved in vaccination, and again a lot of dispelling of myths, which we play a key role. For us, it's important that as many people as possible get access to the vaccination should they choose. And then the final point, next slide please, is I just wanted to share how it's been for staff. And I've put in some quotes for our staff, and you can see some lovely pictures there of our staff and how they've worked tirelessly really during the pandemic to support our residents. Next slide please. I'm not going to read out the quotes because you can see them, but this was, I asked their views around how they maintained their motivation during this time. And you can see there some of our smiley occupational therapists who have really come into their own in terms of what they offer. But what motivates them, as you can see, is that they know that people really need our service and they're feeling that sense of responsibility and wanting to support them. And the other thing that's motivated them is that people are having a better understanding of the work that we do in adult social care. Next slide, please. In terms of what's been different, I mean, the obvious difference there you can see is our staff getting used to working with personal protective equipment, so the masks and the goggles, which, as you can imagine, for some of our service users can feel really daunting. And particularly challenging for some of our service users with hearing difficulties. But the other elements that you won't be surprised to see, and what's been different, is the pace of work in adult social care and the volume, which are common themes that staff have come out, but are actually also the positives around that joint partnership working, where we've all come together as a team to benefit our residents. Next slide, please. In terms of learning, we have, oh, have I frozen? No, sorry. I thought I'd frozen. I can't see the next slide, but the next slide talks about what have we learnt. And I think the key thing that we've learned in adult social care is the level of resilience that we actually have, and actually how it's been really tested during these times. But actually it's been amazing what's been achieved, and also the flexibility that we have shown, that we've put things in place quickly and adapted to the situation, like virtual appointments, for example, to get the job done. And then my final slide, please, just a final quote from staff, which really shows the continued passion and enthusiasm for what we do in adult social care. And at times that's a service that is less visible and it's less understood than perhaps other services across the health system, but nevertheless a hugely important one. Thank you for your time.
Thank you, Melissa. That was a really interesting and comprehensive presentation, very useful to listen to. So thank you very much. Can I ask Councillor Jones to speak on this?
Well, yes, thank you, Chair. Just very briefly to say thank you, and hopefully I can say thank you on behalf of the whole committee to Melissa, and through Melissa to the rest of the staff. There is no doubt that the past 12 months have been a challenging year for many, not just those in adult social care, but let me just say, pay tribute to the work that's been done in adult social care, from some of the early scares, from some of the early pressures around PPE, the partnerships and the alliances we've had to have in terms of some of the care home providers and the like. But alongside all of that, and just in case you've missed it, let me just blow a trumpet for this council. We did take a decision when the government said last March and April that we should be supporting what they were calling hot care homes, designated some care homes in our community that COVID patients could be discharged from hospital, and we said no, that wasn't going to be the right thing to do. and Reading did pioneer the home and hotel step down discharge processes from hospitals to free up beds in the Royal Berks. And now this time, sadly, because this has gone on for so long, sadly now that model has been taken up and embraced across the country, so that other places have been asked to do this and have been asking Reading, how do you do this? And this is something which, as Melissa said, Reading led the way. But generally, whatever role people have played, and there are many different roles that have been played, I would like to pay personal tribute to the dedication of staff and their continuing commitment to seeing this through, working with some of our more vulnerable members of our community. So thank you.
Thank you, Councillor Jones. Yes, and I think everybody would agree the hard work and the dedication is just wonderful. And thank you very much for that report. It was very informative, so thank you very much. Can I just double check and see if we have any of the members that'd like to speak on this? No, I don't think we do. So are we all in agreement? Is everybody happy with the report as it is with the presentation?
Agreed.
Yeah. Thank you. Thank you very much again, Melissa. Thank you. We'll move on now to agenda item 11, which is the Safeguarding Adults Board Annual Report 2019-20, and this is presented for us this evening by Jo Taylor-Palmer. So if I can hand over to you then, please, Jo.
Excuse me, Chair. I'm going to start it and Jo's going to do it with me so she can answer questions, because in fairness, Jo's helped put the report together, but the period was when she wasn't here, so I said if I do the starting bit. But I think Jo's on the line as well, and we'll put our camera on so that members can see her.
Thank you. Cheers.
Thank you, Chair. So I just really want to ask members to note the Adult Safeguarding Annual Report. You will probably know that every year we're required to report annually on our safeguarding activity. And in West Berkshire, just to explain to members, we're in a three-way arrangement. So 3 local authorities, that's ourselves, Wokingham and West Berkshire, are in a joint arrangement, and we have an independent chair, and we have the advantage of being a Berkshire West or a West Berkshire or Berkshire West footprint, and safeguarding is looked at over that that area. So the reports that you've got, extensive reports, are from the board, and part of what we're required to do as each local authority is to do our own report, which adds to that. So the papers that you have incorporate the West of Berkshire report, but Appendix F is the Reading element, and that's primarily what I'm going to focus on this evening in reporting to you. We've had fair amount of activity this year, and you'll see in Appendix F that the situation is somewhat stable. There are a few areas I will just draw your attention to. So we've had a reduced number of concerns for safeguarding in the period we're looking at, which is period 19 to 20. So this is just about pre-COVID. So COVID hasn't, although we had COVID in January and February, we obviously weren't in lockdown until March, so it kind of just covers that period. But we have had a reduced number of concerns, and there's a variety of reasons why that sometimes can happen. And I think I explain quite often that some are perverse incentive, that high can be good and low can be good, because actually low activity might mean that people are recognising safeguarding and are taking action and understand what safeguarding is. High can be that people have been trained and developed and everybody's heightened awareness, so referrals become more frequent. And certainly Jo's been with us now about 5 months, 4 or 5 months, has been working, or even during the COVID, working with providers about what is safeguarding and what isn't safeguarding, because sometimes we get an awful lot of referrals that come in under the safeguarding umbrella, but they aren't actually safeguarding, there for some help or support or some kind of guidance, sometimes not a service. And so, you know, in a sense, whilst the numbers have reduced. We will need to just keep a watch on that and make sure that we are getting that targeted right. And probably the sad reality is that COVID will skew that next year, as you will see when you get the report, because obviously the environment has been very different. But it is something we're mindful of and something we're continuing to work with, just to make sure that we are getting it right and that the messages are getting out there. The number of inquiries that we have, so that's the number of inquiries that go to what I suppose I'd similarly call an investigation. Somebody's contacted us, there's a safeguarding issue, and we go out and visit and we do some form of investigation. That's remained fairly stable throughout the years. One area that you members may remember, and certainly each year, is around the ethnicity and monitoring, that we are targeting our communities in the right way, because we have a diverse demography, and we have noticed that there's been a slight decrease, as you'll notice in the figures, and Joe's continuing to do some work about trying to target and look at how we target communities to just continue to heighten awareness around safeguarding in adults, because quite often it's about those people that see what's happening, and are we targeting that? Have they got confidence in referring, and do people understand what the options are? So we still are mindful of doing that. The area that is highest in the report that you will notice is what's commonly called neglect and acts of omission. And acts of omission are things like medications being missed, a home carer hasn't arrived at the home and hasn't reported it through the processes. So we still have a high number of those referrals which require an investigation, and you will see that's fairly high. And one of the other issues that's increased, which is in common with a lot of the issues around scamming and financial and material issues, is around financial abuse, and that can come in a variety of issues. It can come by neighbours or friends or family or carers, where somebody has dementia, abusing their money, or by purchasing goods in terms of kind of trying not to have inheritance. So there's a lot of issues we're encountering now where financial abuse is certainly one of the things that has grown in the last year. The areas that we've kind of done a bit of work on improving, which are in the report, are around our multidisciplinary working, around trying to set some framework where we have providers where there are safeguarding issues. So that might be within a care home, it might be within a home care agency. We call those serious concerns, where we will meet with providers and we have much more transparent process about what we will do, what our expectations are in safeguarding, and how people respond to that, and how we get improvement in any issues that are in care homes or with providers. And standards of care framework, which is where care isn't quite coming up to standard. It perhaps isn't safeguarding, but we need to support a provider in creating some change and trying to prevent safeguarding. It's much more of a preventative measure than responding to the incident. So we think that's a really good way forward, because that's what we wanted to do, is anticipate and prevent. I think that we've highlighted other things around direct payments and about increasing the number of direct payments, and ensuring we've got a direct payment officer now, ensuring that where people are purchasing care for themselves, that they're recruiting carers that are safe and that have the right credentials, and we provide a lot of support to those people to prevent safeguarding issues. I think that's all I want to add at this point, Chair. Just wanted to highlight some of the areas in the report which members may be interested in, and Joe or I are happy to answer any questions.
Thank you, Shona. Can I ask Councillor Jones, would you like to reply to the report? Or comment on the report?
Chair, I don't know if I'd like to reply to it. That would take a little while. Colleagues will also be aware, certainly those who follow the Health and Wellbeing Board will recognise that, in fact, although this is the report for 2019/20, it was only at the last Health and Wellbeing Board in October that we received the report for the year before that. so the flow of these reports has been disrupted. No, I was simply glad that Shona did highlight the fact that one of the issues that we identified in October and will pursue is the relatively low engagement of Asian and Asian British people in the safeguarding processes. That hasn't fallen off our agenda in any way. It is an issue that we're aware of. I suppose I would beg for people's understanding in terms of the rate of application, of having some time to dig into that. It isn't just a problem in Reading by any means, so it is something that we're aware of and we will follow through on. But otherwise, I think, without being complacent, the report is mildly encouraging. But clearly, as anything, if these reports are worth anything, they'll highlight, as well as the good, perhaps some of the things that we need to do more about, and that's clearly understood. Thank you, Chair.
Thank you, Councillor Jones. Joanna, did you want to respond, or are you? No.
There's nothing more I've got to add, Chair. It's going to the Health and Wellbeing Board, as Councillor Jones has highlighted, and the independent chair, Teresa Bell, will be there at the Health and Wellbeing Board to present that. But yes, I'm happy to take any questions, but no, nothing to add at this stage, Chair. Thanks.
Thank you. Would any other councillors like to speak on this item? No? Okay. As I have no more indications, is everybody happy to note the report?
Agreed.
Yeah. Agreed. Okay, thank you very much. That was the final item on the agenda this evening. So thank you very much to everybody for attending. Thank you for all the reports, and I just wish everybody good night. Thank you very much.
Thank you.
Good night, Chair. Thank you.
Take care.
Thank you, Chair.
Thank you. Bye.
Bye.